Immunotherapy for asthma, the future seems bright. Dr. Jalal Mohsin Uddin, DTCD, FCPS Pulmonology, Assistant Professor, NIDCH Case Study. Mrs. Salma, 40 years old, service holder, is suffering from asthma for the past 20 years and needs medicine daily for her asthma step 4. Her daily requirement used to be symptom-free with inhaled corticosteroids 1000 microgram of Fluticasone with LABA. She is now frequently having asthma episodes with occasional night attacks, eye congestion, and rhinorroea. She is now frequently missing the office and visiting Dr.'s chamber for her asthma. She is looking for anything new that can be tried. What will be the investigations planned for her? What will be the investigations planned for her ANS, allergy test or specific IgE? What new will be planned for her? What new will be planned for her ANS, immunotherapy? The physician's pulmonologists frequently encounter few questions. Doctor, is there any chance of cure of my disease? Doctor, is there any new drug for my asthma? Let us try immunotherapy. A lot of money is spent every year for pharmacotherapy which aims to reduce symptoms, but immunotherapy is the only treatment option that offers long-term modifications of the underlying immune system, and there may be chance of potential cure for the atopic patients. IT can modify the immune response to allergens and alter the course of diseases. It should be based on allergen sensitization, not on the disease. The most common allergens are house dust mite, animal dander, pollens, molds and foodstuffs. Most patients with asthma have an allergic component to their disease. Allergic food and animal can easily be avoided. But some allergens like mite can't be, as it is everywhere. So it is wise to immunize against mite allergen in mite allergen positive patient, along with avoidance of allergic foods and contact with animals to prevent attack of bronchial asthma. When symptoms persist despite optimal medical management, immunotherapy is an option for asthma. The good news is you're going to live, the bad news is you're allergic to cheese. Indications of immunotherapy: presence of IgE-mediated respiratory allergy, skin test or allergen-specific IgE positive for a specific anti-GN. No relief of symptoms with environmental changes or not possible to avoid exposure. Failure to obtain relief with medications or cannot tolerate medications. Unwillingness to take long-term medications. Presence of significant allergic upper airway allergic rhinitis or ocular disease. Skin test. Skin prick test, also called a puncture or scratch test, checks for immediate allergic reactions to as many as 40 different substances at once. This test is usually done to identify allergies to pollen, mold, pet dander, dust mites, and foods. Blood test. A radioallergosorbent test (RAST) is a blood test using radioimmunoassay test to detect specific IgE antibodies, to determine the substances a subject is allergic to. 4 components of asthma control. Allergen avoidance indicated when possible. Pharmacotherapy safety effectiveness easy to be administered. Patient's education always indicated. Immunotherapy in asthma. GINA I asthma intermittent. GINA 2 asthma mild persistent. GINA 3 asthma moderate persistent. GINA 4 asthma severe persistent. GINA Step B pharmacotherapy. Immunotherapy. Allergy immunotherapy is now recommended as a treatment option in GINA report. The update of GINA guideline includes use of allergy immunotherapy SLIT. It recommends SLIT as additional therapy from Step 2 to Step 4 in stepwise treatment of asthma in adult house dust mite HDM sensitive patients. Considering adding of slit in might adult HDM-sensitive patients with allergic rhinitis who have exacerbations despite ICS, provided FEV1 is 70% of predicted lung function. Definition: Immunotherapy. Allergen immunotherapy is the administration of gradually increasing quantities of an allergen vaccine to an allergic subject reaching a dose which is effective in improving the symptoms associated with subsequent exposure to the causative allergen. Definition continue. Or immunotherapy or allergen vaccination involves titrated exposure of allergen to patients to induce immunologic tolerance. Or it is the practice of administering to allergic subjects increasing amount of allergens or allergen extract to achieve hyposensitization to reduce the symptoms occurring during the natural exposure to the allergen itself. Scope of immunotherapy. Disease accepted to be treated by immunotherapy: allergic rhinitis, allergic asthma, allergic conjunctivitis, insect sting hypersensitivity. Disease not accepted to be treated by immunotherapy: food allergy, urticaria, atopic dermatitis. Prerequisites of immunotherapy. Specific allergens must be known. Vaccine should use standardized extracts. Immunotherapy requires a compliant patient, due to its long duration. After a review of the existing literature, in 1998 a panel of experts of the WHO concluded that SLIT is a viable alternative to SCIT. Allergen-specific immunotherapy vs pharmacologic treatment. Specific immunotherapy does not take the position of being an ultimate treatment principle, but should be part of the whole treatment and should be used in the early phase of disease. How immunotherapy IT works. Immunotherapy is a method of allergy treatment that uses an allergen solution that reduces sensitivity to allergens. IT can also prevent the onset of new allergen sensitizations. Administered for several years, 3 to 5 years. Efficacy is maintained for up to 3 or more years after discontinuation. Mechanisms. It has been demonstrated that IT decreases allergen-induced inflammation in allergic rhinitis and allergic asthma. Airway inflammation in asthma may represent a loss of normal balance between two opposing populations of Th lymphocytes, Th1 and Th2. Th1 cells produce IL-2 and IFN-gamma, which are critical in cellular defense mechanisms in response to infection. Mechanisms. Th2, in contrast, generates a family of cytokines IL-4, 5, 6, 9, and 13 that can mediate allergic inflammation. Immunotherapy IT expands allergen-specific Th1 immunity and suppresses the Th2 response, resulting desired effect. Mechanisms. Immune deviation. Successful immunotherapy is associated with shift from Th2 to Th1 lymphocyte immune response. Increases in allergen-specific IgG blocking antibody. Reduces both early and late phase reaction. Reduces concentration of inflammatory mediators. Reduces airway mast cells, eosinophils and eosinophil cationic protein. Types of immunotherapy. 1. Subcutaneous injections SCIT. 2. Sublingual immunotherapy SLIT. Allergen kept under the tongue for 1 to 2 minutes, then swallowed. 3. Intranasal local nasal LNIT. Allergen sprayed into the nostrils as aqueous solution or dry powder. B. May be indicated in patients with rhinitis caused by pollen and possibly by mites. Types of immunotherapy continue. 3. Oral immunotherapy OIT. Allergen immediately swallowed, as drops, tablets or capsules. 4. Local bronchial LBIT. Allergen inhaled with a deep inspiration. SCIT. SCIT is the approved route of administration in USA. It normally involves a weekly SC injection of an extract of the allergen, in solution, in increasing doses until a standard maintenance dose is reached. This dose is then injected SC on a regular basis at intervals of approximately 20 days for not less than 3 years for perennial allergens. Start at early age, so that adverse changes to the immune system can be prevented before they become irreversible. Administration of immunotherapy. Injection technique. Use upper outer surface of arm. Ensure sterile technique. Use 1 ml tuberculin syringe with 26 or 27 gauge needle. Inject at 4-5 degree by deep subcutaneous route. Record any local systemic reaction. WHO approved this modality. The extract is kept under the tongue for a couple of minutes and then swallow it. Dose of allergen is greater than subcutaneous immunotherapy, about 3 to 300 times higher. May be indicated in pollen and mite-induced rhinitis and asthma in adults and children, using maintenance dosages 5-100 times higher than injection IT. RCTs have demonstrated the efficacy of sublingual immunotherapy. Dosage and schedule. SLIT can be administered either pre-seasonally, start prior to the season and stop at the beginning at the season, commonly used for pollen allergy, or continuously, commonly used for house dust mite. The most used regimen includes once daily or alternate day or once/twice weekly administrations. The vaccine or solution is usually administered in the morning with the patient in fasting state, but may be administered at any time of the day. Dosage and schedule continue. SLIT is self-administered, usually self-managed by the patient at home. Thus detailed instructions, schedule of administration, and possible side effect discussions are mandatory. Pharmacology and pharmaceutical formulation. SLIT is currently marketed by several European and Indian manufacturers, standardized either biologically or immunologically. The vaccine of SLIT is available in 2 principal pharmaceutical forms. Buffered solution to be delivered by drop counters, droppers, pre-dosed actuators, or disposable single-dose vials. Tablets with appropriate composition facilitating slow 1 to 2 minutes dissolution in the mouth upon contact with saliva. SLIT advantages. 50% allergologists switched over to SLIT. Rarely produces any reactions. More compliant to therapy. Children can also take. Side effects are extremely rare. Pharmaceutical formulation. Ideally, SLIT should be used in an integrated treatment plan, including avoidance measures with appropriate pharmaceutical therapy. SLIT traditionally involves a build-up phase with gradually increasing doses of 4 to 6 weeks, followed by a maintenance phase with maximum dose. This approach is similar to SCIT but more accelerated. Pharmaceutical formulation continue. The vaccine is prepared in separate vials at increasing concentrations. The targeted subject starts the lowest concentration and gradually increases using the different doses preparations, until the maintenance dose is reached. SCIT versus SLIT. SCIT requires frequent injections, which often results in patient non-compliance, and also has got safety concern, so not liked by many physicians. SLIT, on the other hand, is a non-injection IT method. It is very promising, as it has a very good safety profile, and is usually self-administered at home. Better patient compliance. In pregnant patients, immunotherapy should not be initiated during pregnancy, but can be continued in pregnancy if she has been tolerating it well. No teratogenesis observed. Contraindications for allergen immunotherapy. Absolute. Concomitant use of beta blockers. Risk of anaphylaxis. Previous anaphylactic reaction to immunotherapy. Lack of adequate resuscitation facilities. Serious immunopathologic diseases and immunodeficiencies. Contraindications for allergen immunotherapy. Relative. If FEV1 or PEF are 70% predicted. Unstable asthma uncontrolled by pharmacotherapy. Nocturnal asthma, use of bronchodilator more than thrice a week. Diurnal variation 20%, bronchodilator reversibility 20%. Contraindications for allergen immunotherapy continue. Relative. Other significant medical diseases. Autoimmune disease or malignancy. Unstable coronary artery disease. Pregnancy, do not initiate. Bronchospasm to previous injection. Children 5 years of age. Beta blocker when administered topically, e.g. eye drops. Poor compliance. Side effects. The overall rate of side effects all grades ranges between 3% and 8% of patients. The side effects are usually mild and treatment discontinuation is rarely required. The most frequent reported side effects are gastrointestinal side effects, dose-dependent. Oral itching, swelling, nausea, stomachache, headache, arthralgia. But severe reactions are rare. Ultimate results of immunotherapy. Reduction of the need for drugs in allergic rhinitis and asthma. Studies demonstrated both long-term and short-term benefits. Initial IT significantly reduced symptoms. On stopping IT, partial return of mediators, decline in IgG noted, but seasonal increase in IgE did not occur. Beneficial effects persists for years after full course of IT. Prevention of the onset of asthma. Why immunotherapy fails? Wrong setup. Wrong patient. Wrong allergen S. Wrong dose. Wrong duration. Why immunotherapy succeeds? Right setup. Right patient. Right allergen S. Right dose. Right duration. Conclusion. IT is an effective and potentially disease-modifying treatment in asthma, allergic rhinitis, and stinging insect anaphylaxis. IT works by altering the immunologic response and reduces bronchial hyperresponsiveness. Effectiveness of IT depends on appropriate dose and duration of treatment. IT should be used in association with standard medications. Conclusion. Continue. We, the people of this world, hoping for the total cure of asthma. So far immunotherapy is the only available cure known. Why should not we try to conquer asthma and related airway diseases with the help of immunotherapy? That day is no longer far away when children with asthma will not be afraid of playing. Thank you all. Immunotherapy for asthma, the future seems bright. Learning Pulmonology.